So, anyway, let me also say welcome to everyone. I'm glad to kind of see you here. I'm at UCSD and I run the Center of Excellence, at UCSD. I have to be honest and tell you that we don't see a lot of juvenile HD there. We really don't, and the reason is we have a children's hospital, and Rady's Children's Hospital in San Diego has Jennifer Friedman, who's amazing, and so she really sees, I think, the bulk of the patients that have juvenile HD. We see some, but it's just that we share it, and so she tends to see a lot of them too. Okay, so what is juvenile Huntington's disease, and why is it important to recognize it specifically and separately? Somebody said, well, isn't it just like Huntington's disease? And actually, it's quite different. So I hope that's one of the things that people leave here with today is that recognition of how different it is in many ways. And sometimes I sit and think about the pathology and why it's so different. Because the pathology is a little bit different, but not as different as we don't know it to be as different as you might think. To sort of come up with what we would call the phenotype, the picture that you see, the clinical picture of juvenile Huntington's disease. So it's a genetically inherited neuropsychiatric degenerative disease that starts by the age of 20, okay? And what does that mean? So it's genetically inherited. So that's pretty similar to adult onset Huntington's disease. Genetically inherited from a mother or a father who have the mutant gene, or the imperfect gene, if you will. I don't like that word mutant. Everybody calls it, but I don't actually kind of like it. So I just sort of call it the imperfect gene. And it can be inherited, obviously, from a mother or a father. Juvenile onset HD tends to be inherited from the father. There are some cases where it's inherited from the mother, but we usually write them up as case reports, so it's pretty unusual, okay? And so it's much more common. So why is that? It's because when the gene passes through a father as opposed to a mother, it tends to jump in size pretty significantly, okay? So that's the difference. So when the first time I heard about this and someone said, well, it's because meiotically, men are unstable. I loved it. And I said, no, men are unstable. There's no doubt in my mind, not only meiotically. But what they mean is that when meiosis occurs, which is a process of growth and change in the cells, there actually is an increase in the number of CAG repeats with cell division. Okay, so it's interesting, and that increase can be pretty significant. When the gene comes through the mother, it actually usually increases, or might stay the same, but it might increase by 1 or 2 CAG repeats. When it comes through the father, on the other hand, it can increase by up to 20, for example, or more. Okay, so quite different. Let's go back to that previous slide for 1 sec. Yeah, so neuropsychiatric, because neurologically there are problems with motoric abilities, and we'll talk about that, cognitive abilities, and we'll talk about that, and there are also psychiatric things, and degenerative disease, and I think that's important to say because it's one of the degenerative diseases. Alzheimer's is also, Parkinson's is also, ALS, and what that means is that there's enough cell death that occurs that eventually people die of it. So it actually is a terminal disease, and I think it's important to realize all those words. It's caused by an abnormal CAG expansion of the HD gene. It's located, we know that now, on chromosome 4. We've known that for about 30 years now, believe it or not. And that abnormal CAG expansion leads to I don't want to say mutated, an abnormal Huntington protein that's actually much larger. Okay, so it's a much larger abnormal Huntington protein, folds in different ways, and so as a result ends up being cleaved and ends up clumping in the cells, and then it's kind of toxic to the cells. And we think that's how the cells in the brain die as a result of accumulating the Huntington protein. And the one thing that's really important is, like adult onset, there's a 50-50 chance each child has a 50-50 chance of inheriting the gene. And I'm sure Lisa has seen cases. We have families of 8 and 9 children where nobody gets it, and we have 8 and 9 children where almost everybody gets it. So it's hard to know. We don't really know. And I would say each child has a 50-50 chance. Okay. So the symptom onset, we said, is before the age of 20. It is associated with higher CAG repeat lengths. They're often in the range of 50 to 60. You know, if I look at the repeat length in our adult population, the mean repeat length at our clinic is 42. So that is that's the most common CAG repeat length that we see in adults. But in juvenile onset, it's more like 50 to 60, okay? Fewer than 10% of people with HD have juvenile onset HD. So you're special. You're special. About 5 to 10%, we say. And only about 1 to 2% of people with HD have onset before the age of 10. And when that occurs, the age of 10, when that occurs, we call that childhood onset. Okay, so juvenile onset before the age of 20, childhood onset before the age of 10. Do you think you can get adult onset disease? Can you be diagnosed in your 70s and 80s? What do people think? Yes, absolutely. And it was very funny. We had a man who walked in one day, and I looked at him and I said, "You have Huntington's disease?" And he looked at me and he said, "I'm 81 years old, young lady. There's no way I have Huntington's disease." And I said, "You do." And so we had to test him. Okay, what is this? Let's go back. Yeah. What does this show? This is important, actually. What it shows here is the number of CAG repeats on the y-axis and then the onset age on the x-axis. And what you can see is that the higher the repeat size, you see up there, the 60s, 70s, 80s, you can see that onset is actually quite early, before the age of 10 or 20. And this is data from the New England HD Center. Okay. Sorry.
It's okay.
So this is just to really reinforce that notion that, you know, when you look actually at the highest CAG repeats, and that's, you can see up there on the right, that's sort of nicely circled, not a lot, so not a lot of cases, the frequency is low, but those are the people that have very high CAG repeat sizes and very early onset. And when you look at the 5-year ranges, so this is onset ranges, way down here, you can see that the frequency is actually quite low. Okay. So how do we get from 40 or 42, which is the mean for adult onset, to 60? And again, we think that it's because people may, or parents may actually have a mutable normal allele, or some of them may. So they may not look as if they have Huntington's disease in their lifetime because they have a lower number of CAG repeats, and they don't show the Huntington's in their life. So we call that reduced penetrance. In other words, they don't necessarily show symptoms. A mutable gene is an unstable one and can actually increase, as we said, in a father much more than a mother, increasing from one generation to the next. And we call that whole process actually anticipation, when the next generation gets more repeats than the generation before. And as I mentioned, paternal transmission, it could be up to 20 or more jumps in the number of CAG repeats. Okay, thank you. So juvenile onset HD affects memory, it affects movement, and it affects mood, okay? All of those things. Actually, adult onset HD does too, but there are some important differences. Changes in thinking we talked about, psychiatric and behavioral disturbances we will talk about. And we said different from typical adult onset HD, particularly a child under the age of 10. And yes, unique challenges that Lisa and I are going to talk about. So typical initial symptoms: stiffness in the legs, clumsiness in the arms and legs, decline in cognitive function, changes in behavior, seizures. Seizures are very common in juvenile onset HD, and we don't really see it that much in adult onset HD. So that's quite different. A lot of difference in oral motor function that we don't really see in adult onset HD either. So problems with handling boluses of food in the mouth and using the mouth. We do see some chorea, but it's much rarer than in adult onset, and the behavioral disturbances are there and also different. There's a decline in cognitive function, very common, very early. We do see it in adult onset HD too, but it takes a little more time. It's a little bit, it's initially subtle, but progresses. Patients may just appear distracted in juvenile onset HD, or easily overwhelmed, have difficulty completing tasks, for example. They may start to lose skills or milestones that they previously had, and they definitely have difficulty learning new skills, telephones, phones, that kind of thing. There can be declines in school performance. Sometimes that's the first thing we hear about, okay, that their school performance has declined, or that they have attention and concentration difficulties, problems with multitasking, doing more than one thing at the same time, and decision making. And then in terms of movement and motor skills, obviously, worsening of motor skills, changes in speech, we see that pretty commonly, again, that oral phenomenon. Riding a bicycle, that can actually change. They may have previously been able to ride a bicycle, and now they can't. Throwing a ball, that may change. The picture's a little bit different. In adult onset disease, we see lots of chorea. In juvenile HD, we see lots of rigidity and stiffness, more like Parkinson's disease, which is interesting. So rigidity and stiffness, dystonia. There may be abnormal tightness or posturing. You may see, postures like this, or torticollis of the neck, different things like that. That's pretty common. Difficulty walking, clumsiness. I mentioned this already, the poor oral control, drooling, difficulty swallowing. And as it says here, chorea is rare, but it can be seen. Yeah. Psychiatric and behavioral changes, depression, very common, also very common in adult onset disease. Sadness, tearfulness, hopelessness. Attention difficulties or hyperactivity, a little bit different than in adults, that we see that. Hypersexuality, we definitely see that. Aggressiveness, impulsivity, explosive behavior, and obsessive thinking. Obsessive thinking, very common. And then behaviors can be pretty unpredictable and difficult to manage. And sometimes we think, well, is this juvenile HD or just a teenager? But, because it's a different age group too. So we have to really think about all of that. There can be lots of substance abuse, and we actually think about that right away, drugs, alcohol, that kind of thing. And of course, probably not surprisingly, cause a lot of disruption in families. It really becomes difficult. The seizures can be a presenting symptom, which is interesting. We had one case where that was the first thing that actually occurred, and that was really the milestone, the onset of juvenile onset HD in a patient. So it can be a presenting symptom. We don't really see that in adult onset disease. But about 30 to 50%, the number is actually closer to 40%, usually children with juvenile HD having seizures. And they can be any of the types of seizures that we know about. Babies and children can have seizures for lots of other reasons, so it doesn't mean that this is juvenile HD, in everybody who has a seizure, but just so you know that. And then young onset adult HD, not everyone fits perfectly into being a juvenile or being an adult onset HD person. So this can actually be difficult, and we kind of always stress special attention to an individual's presentation and their particular needs. Yeah. So what are the challenges and why? I would just say many of the symptoms are found in other conditions, so we don't really know, is this the beginning or not? I mean, a seizure is a pretty significant event, so I think that tells us it could be. But sometimes I think we start to think, well, what else could it be? We try to find out anything else other than juvenile HD if we're, looking at this. The genetic testing doesn't necessarily mean that the symptoms are due to juvenile HD. If you tested a baby at one day, they would have the gene mutation, It's really the onset of symptoms that marks the point at which we make the diagnosis, okay? So unfortunately, if the symptoms happen to be due to something else, which they could be, then we can't really make that diagnosis. Sometimes there are very complicated family histories. People, their parent might not be affected yet. If it's a very young parent, we had a situation like that. Early death of a parent before they were affected. They say, no, nobody had HD in my family. I don't know what you're talking about. We didn't have any HD at all. So that was because of the early death of that parent, maybe in an automobile accident or something. Misdiagnosis or lack of diagnosis in an affected parent. We're always told about schizophrenia or something else, which isn't. And then, non-paternity. Sometimes who people think their father isn't their father, and that's, also pretty common. And then adoption. A lot of people have told me, well, I was adopted. I don't really know my birth family. So all of these things can actually add to the complications of or the challenges of diagnosing it. The diagnostic criteria for childhood onset HD has to be onset before the age of 10. There has to be a family history of HD, and usually 2 or more of these things that are listed. So declining school performance, seizures, oral motor dysfunction, rigidity, or gait disturbance. So these are the things that we look for. So this is quite different. I don't see, Korea isn't there, so I think it's really quite different from the adult. Yeah. And then the evaluation for possible JOHD, you want to?
Yeah, I'll do this.
Yeah, go ahead.
So my name is Lisa, and I am a social worker. I am not a doctor. But if you are concerned about JOHD, concerned about your kiddos, concerned about family, friends, whatever it might be, talk to your healthcare provider about it. Now, keep in mind that, your pediatrician or pediatric neurologist and things like that might not know that much about JOHD, but definitely talk to them about what some of your concerns are. We would also recommend either seeking a referral to a Huntington Center of Excellence or just calling a Huntington Center of Excellence. And you can talk to someone that has some knowledge about JOHD. At my clinic in Northern California, you would talk to me. At other clinics, you'll talk to like a nurse case manager or different people. So anyways, always ask questions, and I would say ask questions before you actually do the blood test. There are situations where, you can test a child and they come back with 40 repeats. That tells us that the 40 repeats, they're gonna get it probably in adulthood, not likely childhood, which means if they are having seizures or difficulties in school, it's likely due to something else, okay? But what to expect when you go and you ask questions is to, they're going to want to take a medical and a neurological history. What was the birth like? Was there any complications during the birthing process? Things of that nature. Obviously, a family history. A genetic counselor would probably do the pedigree and just kind of see, the family tree, if you will, and see how what HD looks like within the family. We'll go through a neurological exam. It can be pretty kind of intense for kiddos, so sometimes explaining this to them and what's happening is a good thing. And then, obviously if you were at a center of excellence, we'll talk to you about discussion and a plan and things of that nature. We'll also need information about what's going on in school. And then just understand that a diagnosis of JOHD takes time. It's unlikely and not extremely common that when someone walks into our office, we're like, yep, they got JOHD. That doesn't happen quite frequently. Usually it's kind of a, everyone's like, yeah, no. It's usually kind of a process where we meet you the first time, we gather all this information, and then maybe we reevaluate in 6 months or maybe reevaluate in a year and kind of see what kind of changes has gone on. Because as Dr. Corey Bloom said, there could be other things that are going on with a child, coming from an HD family. I mean, there's already family disturbances and emotional things that come out for kiddos. They express themselves in different ways, things of that nature. So just know that you're not going to go in there like, on your Friday and come out with a diagnosis in most cases. And then, of course, routine follow-up is really important. So if you do come into a center of excellence, it is important to stay in contact with them, do follow-ups at least every 6 to 12 months, if not more frequently if needed, so that we can really kind of support you and get the information you need and help with school and stuff like that. These are some of the risks of, sorry, he's probably getting mad at me because I'm not using the mic. These are some of the risks of testing early, potentially. In general, we do not test persons under the age of 18. This is an adult onset disease. It is classified as an adult onset disease. Obviously, there's a juvenile form. We're talking about it today. But because of that, we don't test children under 18. We want children, well, adults, to have their own right to make their own testing choices. What is it, Mara? 93? We'll say 90-ish% of people choose not to test for Huntington's disease. So that's, 90% of the people here, let's say, that are at risk are like, I'm just gonna go through life, and if it comes, and I'll address it then. If not, that's okay. But then there's 10% people that do want to know. So we wanna give people the chance to make that decision for themselves. Sometimes, like I said earlier, we can attribute symptoms to HD when it's not really HD. We like to blame HD for everything, right? We're like, oh, that's HD, when it may not be HD. It can delay a correct diagnosis. It can stigmatize the child, meaning, if we tell them we tested you for HD and now you're positive and you have juvenile, Huntington's disease, or you have adult onset Huntington's disease, so you don't have symptoms yet, but they know that they have the gene expansion, they might not pursue maybe their dreams or follow their passions and do some of that stuff. So we don't want to do that. There's some insurance issues there. Obviously, once you're tested and it's in your medical record, it stays in your medical record and it follows you throughout your lifetime. Employability, anyways, yes, there could be some issues there. Obviously, there's lots of effects on the child and the family, and then obviously social effects and things of that nature. So we usually, as a clinic, as clinicians, do not want to test a child under the age of 18 unless it's really clear symptoms that lead us to believe that it could be juvenile onset. How many of you are associated with a COE, whether you're an adult or a child or anything like that? 1? Oh, no, 3. All right, nice. So for those of you that don't know about Huntington's Centers of Excellence, we have all those people listed up there in the corner: neurologists, like Dr. Corey Bloom, psychiatrists, social workers, neuropsych people, genetic counselors, physical therapists, research coordinators, sometimes there's dietitians, speech therapists, all kinds of people that can help support you. It's kind of I call it a one-stop shop where you can get all these people. So if you are a family that is concerned about JOHD, already been diagnosed with JOHD, this is a good place to go because you can get lots of information and lots of support. Yes, sir? Oh, nice.
So they haven't been classified as a COE yet. They've been trying to.
Yeah. But we'll just call them a center of excellence then, because obviously they're offering all of this. Unfortunately, that doesn't mean that they get any money, and that's probably what they're looking for. But if you are at a COE or not at a COE, it is important that you get therapy, physical therapy, occupational therapy, speech therapy sort of on your team, whether that's through referrals, close to home, through your community, or through your healthcare provider. Dietitians are really important when you're looking at Huntington's in general or just JOHD, so that you know feeding-wise how to do that and how to do that safely and avoid other complications related to ingesting food. Obviously, a primary care physician and pediatrician, you still want them involved because not everything is HD or JOHD. Sometimes people just get a virus and they have a cold And then that's where the pediatrician comes in. Dental care is obviously very important. It is sometimes hard to find a dental provider, especially if your loved one has lots of movements and chorea or lots of dystonia, and it's hard for them to open their jaw and things of that nature. But dental care can work with the COEs definitely, so that we can, help make sure that you get good oral health. And then there's palliative care, which is basically symptom management. We're going to look at quality of life. How can we, help you as a family and patients, have a better quality of life, even though that you're living with Huntington's, which is very, very challenging. Do you want me to cover this one? Okay, so medical, what's up?
You're on a roll.
All right, sounds good. So medical care, each person, of course, has their own individual course. If you've seen one person with HD, you've seen one person with HD. Not all HD people or JOHD looks alike. So you really want to make sure you get care tailored to your specific needs and your family's specific needs. But treatment should focus on all of these areas. Education is key. Education is the thing that's going to empower you. It's the thing that's going to give you the confidence. It's going to give you the resilience, the ability to cope with the different things that arise during your JOHD journey. Obviously, you want to treat the movement, cognition, the behavioral, the psychiatric issues, the seizures too, as well as any psychosocial dynamics. That's why it's important to have a collaborative, multi-professional team involved. This is the JOHD handbook. It's really fantastic. Dr. Martha Nance, who's a legend in the HD community, wrote it. This is the QR code that will get you there. This is about 10 years old. I have insider knowledge that it's being rewritten. I don't know when it will be done, but we'll just say, I don't know, give it a year or so. But most of the information in here is going to be really, really helpful for you regarding JOHD. There's information about things that you can share too with your schooling and your teachers and your community, so that they can learn more about JOHD and what you might be going through. You want me to do this one?
Yeah.
Oh, no, this is you.
Yeah, I can
Dystonia myoclonus, that's
can
a
do
doctor right there.
So how about, all right, we diagnose all these things, and then the question is, what are the treatment options that are available? And I think that's something that people always say to me after we go through everything. They're like, okay, well, what kind of treatment do we have? So I think early intervention is probably one of the most important things, and that really, I can't stress that enough. Safety devices, or even thinking about safety, thinking about equipment that might help, that might things safer, all really, really important. Physical therapy, we really try to get people into physical therapy as soon as we can. Range of motion, as I mentioned, safety measures, fall prevention. We often will ask one of our physical therapists to go into the home to do a home safety evaluation, to really look and kind of see, take that rug that looks like people can slip on it off the floor, move furniture a little bit if we can, just to make a safer path, grab bars, all of those kinds of things in the bathroom. So just anything that they can kind of suggest that might make it safer for bathing and those kinds of things. Rigidity and spasticity, we definitely have some medications for. I think it's all on the next slide, but dystonia, which we'll talk about, myoclonus, which I'll talk about, chorea, and tics. Yeah. Okay. So rigidity and spasticity. So if any of you have seen Parkinson's disease, you know that people get very rigid, very stiff. They get bent a little bit, and they make small steps. So we don't see that in juvenile Huntington's disease, but we do see rigidity or stiffness. Sometimes it can be very difficult to bend an arm or a leg. That's how stiff it is. Spasticity is what we call an upper motor neuron sign. It's actually kind of like, we call it the knife clasp phenomenon. With spasticity, you'll have stiffness. You try to move an arm, it doesn't work, and then suddenly it gives way. So we call that the clasp knife phenomenon. And we see that a lot. So there'll be lots of stiffness, and then it gives way. So what do we do for that? It's very uncomfortable. People actually develop pain as a result of the stiffness and spasticity. We often will try to do range of motion exercises, as you can imagine, sometimes through physical therapy, and we'll try to see if we can't teach that to the patient or family members to try and work on that. There are medication options, believe it or not, for rigidity. We actually will sometimes use a medicine that we use for Parkinson's disease called Sinemet. It's a combination of carbidopa and levodopa. And this is important because this medication actually can help with the rigidity that we see in juvenile onset. Amantadine is another medication that we can use. Baclofen for spasticity, and clonazepam or Klonopin. That's a Valium-like drug, and sometimes people say to me, "Oh, I don't want to take something like that or anything." But sometimes in small doses, especially at night, it can actually be very, very helpful to really relax the muscles, and so that people can finally go to sleep. And of course, Botox, botulinum toxin therapy, is something that we use quite a bit. You have to realize that you have to be careful and you have to have someone who's really skilled with it, because you don't want to give someone too much because it might actually paralyze the muscles, for at least the next 3 months. So we don't do that. But we can actually take really painful spasticity and improve it by using Botox. We can use it in hand muscles. We can use it in arm muscles. We can use it in leg muscles. This is not rigidity or spasticity, but sometimes if there's a lot of drooling, for example, we can actually even do injections into the salivary glands that can actually decrease the amount of fluid that's coming out of the salivary gland. So that can help a lot with drooling, just Botox. Okay, so dystonia is actually involuntary twisting or posturing. And I remember I mentioned before, sometimes people have torticollis, so you'll see that the neck is sort of turned or twisted, and that's one thing that's can be very painful, and some Botox is really, really helpful to get rid of that. We may have to do it every 3 months, but it can actually be very, very helpful for the dystonia. Important to remember that dystonia can affect any body part. You may see it in the neck, but you may also see it in an arm or a leg. Okay, and so especially if it's a little more widespread, we might use a medication. It's because it's not just one muscle that we have to go after. It can be intermittent at first and then more sustained. So in other words, it might be that sometimes you only start to see that twisting or dystonic motion during certain things, and then all of a sudden you start to say, oh, it's there all the time now. So sometimes it can be more sustained. It can be very uncomfortable, and as I mentioned, Botox therapy can be very helpful for that, as can the Baclofen that we use for spasticity and clonazepam. Myoclonus, this is an incredible movement disorder, I think. So in babies, you sometimes will see an infantile spasm kind of a movement, and I kind of will tell people that, and, the baby may just do that quickly, That is actually a myoclonic jerk. It's a jerk of the whole body. Sometimes when you're falling asleep, tell me how many people have had this sensation, you're falling asleep, and all of a sudden it seems like you stepped off the curb, okay? And you're like, whoa, that is a myoclonic jerk, believe it or not, myoclonus, so it's a myoclonic jerk. Sometimes people will you see it in other diseases too. I see it in Alzheimer's disease a lot, for example, movements just like that, So you see it here in juvenile onset HD2. So the drug that really works the best is clonazepam or Klonopin. It's a very, very good drug for that. Sometimes patients don't care as much about it as people watching them and loving them do. So they don't want to continue to see it. And so they basically will ask for the medicine, even though the patient will sometimes say, oh, I don't care, I don't really need it. But it really does help. And I sometimes can look at the stress levels of everybody involved. It's a family disease. And I can sort of say, well, maybe it's good. Let's try it. Let's just try a little low dose and see if that doesn't help a lot. And I usually give it at night if I can, because it actually is good. It helps with sleep, and it doesn't make people be sedated during the day. Chorea is something, as I said, that we see a lot in adult onset disease. We see somewhat in juvenile onset disease. These are involuntary, brief, random movements. In the hands, it may look like piano playing. In the feet, it may look like toe playing, sometimes splayed toes you can see. Sometimes you'll see lots of movements of the shoulders. You'll see movements of the trunk. And so all of those movements, and they can be quite widespread in the body, sometimes lots of movements of the mouth, lots of movements in the face. So we have very good medications for chorea. That's really the one area where we have lots of good medications. First started with something called tetrabenazine. We did those clinical trials. Zenazine is another name. Then deutetrabenazine came out. This was Austedo, and more recently valbenazine or Ingrezza. Very good medications, very effective. And when chorea is really widespread and very difficult to control, we sometimes will add a little bit of either Zyprexa or Risperidol, Abilify, to the tetrabenazine or valbenazine or deutetrabenazine. Tics, very common, and interestingly, we have a patient who actually has a tic disorder, and that was all he had for the longest period of time, and then developed more widespread chorea, and we tested him for Huntington's disease, and he had Huntington's disease too. So he had been diagnosed as a teenager with Tourette's, and now he's about 45. And he has a low number of CAG repeats, just 40. And so he now has gotten a diagnosis of Huntington's disease too, because of all of these other difficulties that he has, chorea, et cetera. But tics can be seen. Tics are very stereotyped movements, and so sometimes it can be something as interesting as a person takes off the pair of glasses, they look like they're taking off a pair of glasses constantly, that kind of thing. It can actually be vocal. A tic can be vocal, and sometimes you'll hear a noise, it's the same noise repeatedly. They can be suppressible. But the urge is very strong with a tic, and so even if people try to suppress it, it'll eventually come out. And so motor tics, movements, or vocal tics, utterances, as we said. Examples would be things like eye blinking. If they're more complex, there might be eye blinking and taking off a pair of glasses that may look like it, or smoothing hair behind the ear, or just a movement that they constantly do. There's a famous tennis player from Spain. I think he just retired, actually, but he was a very famous, do you know who I mean? Nadal. Yeah, Nadal, yeah. So he actually has terrible tics. I don't know if you've ever noticed him as he goes to, like I said, wow, as he goes to get prepared to serve, he goes through an amazing routine, He'll do something with his mouth, then he'll put the hair behind his ear, then he like this, then he'll grunt, and then he'll finally serve. And he does the same thing over and over and over again. So it's very amazing. So I don't know, I assume he has Tourette's, but I don't know that, for sure.
We haven't diagnosed him.
Yeah, we don't know. We have no idea, but amazing tic disorder. Anyway, treatment options there too, which are very good. Clonidine and guanfacine, and neuroleptics, Zyprexa, Risperidol, Abilify, and Haldol. So lots of good treatments really for tics.
Do you want me to take this one?
Yes,
All right.
please.
So we're going to move from the motor stuff. We're going to talk about memory a little bit. So some of the management strategies for memory or cognitive changes, thinking changes, things like that. There's not, should I say any medication? There's limited medication out there that has shown to show any data that it improves memory or helps with memory. So a lot of this stuff is going to be personal, family, and environmental strategies that you use to sort of just make the environment a little bit easier to manage when you're having memory changes. So you want to try to provide a stable and predictable environment. You guys all come from HD families, but our brains, all brains, HD or not, like routine. So the more we can predict something that's going to happen and plan for it and be prepared for it, the more comfortable we feel. That's just normal human behavior. So if you're having memory changes, of course you still want that. So it's really even more important to have a really kind of stable and predictable environment. You don't want it to be too chaotic or too, every day is something new, because then their brain is just working overtime and trying to figure out what's going on and how do they manage it and what's going to come at them. You want to create a daily schedule, wake up around the same time, breakfast around the same time. If you have specific chore, someone's getting hit on the shoulder over there. If you have, chores, like laundry day is Tuesday or shower day is Wednesday or what, have those things in place. And those things are so that your brain goes on autopilot, right? How many of us drive to work and we don't even remember driving to work because we're just on autopilot? Well, the routine is going to help you get on autopilot, where it's just like, it's Wednesday at 10 a.m. This is just when I shower. This is just how it works. And your brain doesn't have to do a whole lot of thinking. So you kind of save your brain energy or your brain power or brain effort for other things. Simplify tasks and decisions. Do you want orange juice and apple juice instead of, what kind of, juice do you want me to buy at the store? And it's like, cranberry, grape, orange, apple, it's just too many things to think about. So simplify things. If you can minimize distractions and noise, our brains like quiet. That's how we rejuvenate and sort of, get grounded again, and so that we can make better decisions. Reorientation, if someone is sort of fixated on something or can't let something go, if you can find a way to sort of distract them. Someone might be self-diagnosing themselves back there. But anyways, distraction is a good technique for all of us if we're kind of just getting fixated or perseverating on something and can't let it go. Creative reminders. So, having Alexa say, hey, it's shower time, or hey, it's bedtime, or having reminders on your phone or your watches or things like that. Sticky notes in the house, on the bathroom about brushing your teeth or washing your hands afterwards, or different things can be really helpful. And that way mom and dad or sister, brother don't have to be the quote unquote nag. Modifications at school. This is going to be 100% necessary. If you do have a JOHD diagnosis in your family, they should be getting an individualized education plan through their school, if they're still in school. So this is the QR code that will take you to this, which Huntington's Disease Society of America has created. It's very, very good. So definitely take a look at this if you're looking to get an IEP, even if it's an IEP for something else. It's good information, but you're going to want to do that with your school, and you're going to want to do that as soon as possible. This is going to be the thing that helps get accommodations at school, keeps them safe, helps them achieve their goals, helps them build their confidence, gets them any equipment that they might need, or safety assistance or anything like that they might need. And then you can do in-services with us, social workers. There's like 101 HD social workers across the country. Some of us have more experience with JOHD than others, but you should reach out to your Huntington social worker and talk to them about potential in-service for your school. I've done in-services both with school administrators, teachers. I've also done in-services with the students, so the students understand what, this person is going through and how they can help them, and, why are they having these movements or these jerks or, whatever, so they're not sort of ostracized or bullied or anything like that. Any questions about any of that? All right. I think this is you, unless you want me to do it.
Oh, I'm happy to. I'm happy to. So, management strategies continued. How about things like depression and anxiety, apathy? These are amenable, I should say, to medication, as long as people want medication. Sometimes people say to me, no medications, I don't want medication. I think we try to work with people, but as we said, it's a family disease too, so sometimes the decision becomes a little more extensive in terms of input. But I think, depression, we really do have some good antidepressants. Anxiety, we definitely do have some good anti-anxiety drugs. We don't have any drugs for apathy. I'm just going to be honest with you. It's a very interesting phenomenon. I think I never quite appreciated it as much as I should, but you know, it's probably the thing that, at least in adult onset, you know, disrupts more marriages than you could imagine. You know, I think it's sometimes I feel like I'm a marriage counselor, but I try to explain to the injured party, you know, what apathy is like and how difficult it is. And it's the same thing for juvenile onset HD. You know, you'll have people who sit on the couch, and the family, you know, the spouse will be like, they sit on the couch all day and they just don't do anything. And I tell them they have to do one thing by the time I get home. And I get home and that one thing isn't done. They didn't get off the couch and do it. And I'm furious, you know, like, so I think it's really hard. Apathy is really a lack of motivation. You know, as humans, our motivation, our ability to put a path of behavior together to enact something that we know we either need to do or should do or whatever, it's pretty unique. It's a very sophisticated thing. It requires a lot of executive functioning, and it requires a lot of our ability to kind of say, okay, get up, do this, move to the thing, do this, you know, take that out, and that is completely overwhelming for juvenile HD patients. It's very, very difficult to get up and put in action the things that they need to do to accomplish something. And so it's that inability to motivate themselves, that lack of motivation, that's really, really difficult. And we really don't have a medicine for that. We've tried everything. We've tried stimulating antidepressants. We've tried amphetamine-like drugs to kind of stimulate people. But in general, it's beyond that. It's the way the brain is kind of wired, that it can't really put that series of steps together to initiate something. It's very, very difficult. So what I tell people, though, is make his friend come over and get him and take him out. Or make this person, you know, this relative come over and get him and take him to lunch, or take him to the movies, or take him to a ball game, or, you know, whatever. Then they'll go. It's just, they'll go. They're not going to say no, they'll go. It's just when you say, oh, I want you to go and do this, they're like, yeah, okay, you know, and nothing happens. So there's no medicine, but the way around it, I feel, is to just go and have someone go and get them and take them, because it will happen then. Or do something with them. You want to clean up the room, do it together. You know, cleaning up the room together, the clothes or laundry, do it all together, because that's the only way it's going to really happen.
I'm going to interject just here because
please.
I had a support group. I lead a support group, and one of our HD persons, yes, it's adult onset, but she was talking about, she is still working, PS, but she can't cook for herself. And she described it as, she said, I look at the recipe and I know what I want the end result to be, but her mind goes blank. Mm-hmm. Someone's nodding their head back there. Yeah. Just blank. She can't think of, she sees the recipe, she sees the ingredients, but she doesn't know how to put all those things together, even though there's instructions. She just can't gather her thoughts to be able to do it. And if you think about it, if you think about showering is an easy thing, right? Seemingly. But if you think about all the steps that you take before you even get in the shower, right. So you got to go in the bathroom, make sure you have a towel, turn on the water, make sure it's not too cold, making sure it's not too hot. You got to wait for it to get cold and hot. Then you got to get in the shower without slipping and falling. And then you get in the shower, and then you got to wash your hair, and that's a shampoo and conditioner for some of us. And then you have to take a different soap and wash your whole body. I mean, there's a lot of steps involved. So if you have cognitive impairment and someone says take a shower, they know what you want them to achieve. They just don't know how to get there, because there's 8,000 tasks in between there, and they're just so overwhelmed. Right. Then they're, it's kind of like lead in their booty. They just kind of get stuck and frozen. Yeah. I think someone understands.
My mom used to say, the fire would be on the stove, she's like, miscommunication right there.
Yeah.
So she shared that, her mom had some difficulties with forgetting to close the refrigerator door, and she would see it open and she would know what she needs to do, but she just couldn't formulate how to get that task done, and some of those things. And some of the things are safety issues, especially if they're leaving the burner on or dropping cigarettes or different things like that. So sorry to interrupt. Go ahead.
Yeah, no, next slide. Good. All helpful.
Oh.
Great.
5 minutes and then
Yeah, all helpful, great, thank you. Next slide.
Oh, you want me to do this one?
Yeah.
So these are kind of just management strategies for mood, so not medication related, but you can read them. It's really hard. Is it they're hormonal teenagers, or is it JOHD, or is it both? That can be really hard, so that's where you use your team to help navigate those sort of things. Aggressiveness, impulsiveness, just safety plans, obviously you want guns locked up, ammunition should not be in the gun and or should not be near the gun. The person with Huntington's disease or a child should not have access to either one of those things. You can also use medications to help with some of those thinking, or some of those behaviors. Obsessive thinking, redirection, things like that can be helpful. Meds can also be helpful. If they're having psychosis and hallucinations and delusions, definitely talk to your doctor about it, because we do need to get them on some medications to help with that. And then I guess a plug for social workers again. We want to stay employed, so please call us. We want to do an in-service and help educate you. Oh, and this is addressing hypersexuality. It does happen. Kids have hormones, and as we grow up, they have sexual desires just like the rest of us as adults do. So managing some of these things can be hard, and sometimes we don't think about it because they're our kiddos, right? And we just don't think of them that way. But you do have to recognize these things. So especially for females, we want to manage their menstruation hygiene, so whether that's getting them on the pill so that their, period is a little bit more routine, teaching them how to clean themselves and some of that, contraceptives to avoid pregnancies if that's something that's concerning for you. Obviously, education, you should still talk to your children regardless of whether they have JOHD or not about the birds and the bees. Obviously, you're going to have to do it in a more developmental approach and what's most appropriate for them based on their stage. Sometimes there is treatment with medication that we can help, and then a lot of just discussing and redirecting. Some of the stuff you're not gonna, we had a JOHDer and she hugged everybody, strangers included. It was awesome when you knew her, and it was great to get that hug, but not so awesome if you're a stranger and you don't know this kid that's lunging at you with a hug. So, you just kind of have to be aware of these, work with your team so that you can manage them.
Yeah, and then seizures, we did mention, this is unusual. We don't see this in adult onset HD, but in kids it's actually very common. It's really, the workup is very similar to any kind of a seizure. We tend to do brain imaging, looking to see if there's a lesion in the brain. We do an EEG. Sometimes we'll do a prolactin level, to see if they've been having a lot of seizures. And of course, there are medications that we can use, anticonvulsants, Keppra, Depakote, Lamictal, Tegretol, even many more than that now. So,
right.
Yes. Okay. And then other symptoms, sleep problems, good sleep. We've got good medications, like things like trazodone, developed as an antidepressant, not addictive, things like that to help. Obviously, pain. Sometimes, it's the rigidity or dystonia, and so those are the things I want to go after directly. I don't want to just give them a pain medication, but I really want to go after the rigidity or dystonia. If we can't really identify something, we just try to use the appropriate medication for the pain. Constipation can be an issue. The diet's important, stool softeners, those kinds of things. And then sometimes we see itching, which is really interesting. It's definitely a neurologic phenomenon. I see it in multiple sclerosis too, and it's basically probably a neuropathic mediated thing. And we use gabapentin or Neurontin pretty functionally for that. Next. Nutrition, very, very hard to really get people fed well once swallowing becomes an issue. Choking can be difficult. We get our swallowing people involved, our nutrition people involved. We talk to them about small meals, frequent meals, very slowly, using a straw, pureed diets, those kinds of things, and then very nutritious food. Avocado, mashed avocado, really good peanut butter, things that are really dense and sort of high in calories. Shakes, for example, Ensure, those kinds of things. Feeding tubes are very personal decisions, and everybody has different opinions about feeding tubes or not. The one thing I would just point out the science part of me is feeding for calories is one thing, and you can put a feeding tube in and make up the calories that maybe a person can't swallow. But if they can't handle their secretions, their saliva, that's actually going to all continue to end up in their lungs and cause aspiration pneumonia, which is, of course, the thing that we worry about with food. So it becomes a little more complicated, and I think those are, big issues that need to be discussed with the team. Communication, very right to talk about the electronic communication devices. The United Cerebral Palsy organization actually provides it free to many of our patients, and we really have appreciated that. So that's great. Next slide.
This is me. So there's a lot of adaptive wear and strategies and resources to help with maintaining independence with dressing and or ease of dressing if someone is having lots of chorea or wheelchair bound or anything. So there are companies out there like Tommy Hilfiger, Cat and Jacket, Target, JCPenney's. Are they even still around? Anyways, JCPenney's. There's lots of other companies that are coming out there with adaptive equipment. So it's like, Velcro up here so it's easier to get over someone's head. If they're a child and they do have a feeding tube, there's some clothes there so they can't get to the tube to actually pull it out, although a lot of people are really creative and they somehow get to it anyways. But there's different things to make life easier. If you guys have not heard of Kissick shoes, I swear my doctor has stock in this because she tells everybody, and they're amazing. I even bought a pair, and I took them to the airport coming here, and no joke, they really are slip-ons. I thought it was just kind of a marketing scheme. No, they really do slip on. You tie them once when you get them, you slip your foot in there and you slip in there. It's so easy to do, especially if you have kiddos. They can just put it in there. You're not screaming, yelling at them to get their shoes tied for about 25 minutes. These are some of the other things. There's lift wear to help with eating, independence. There's, tricycles so they can still go bike riding with friends and family. There's adaptive video game equipment. Who knew? There's different beds. These are wheelchairs just for comfort and getting people around and things of that nature. Let's see. You want to talk about? Well, we only have. Yeah. So let's just go for you as caregivers and parents and families. This is the best statement. You be kind to yourself. Give yourself grace. You can do anything, but you cannot do everything. Please utilize your team. That's what we're saying. Utilize your village. Your village is here this weekend. Meet those people. Go to support groups. Talk to your HD centers of excellence. Talk to your social workers. Get involved. Build yourself a community that understands. There's going to be some people that don't. Those people aren't your village. You're not going to call them. But find the people that will. There are people out there that really want to help you. And know when to ask for respite. And take the time for yourself. And, all of us as parents, we still need time away from our kids. Doesn't mean we don't love them, but we do love them a little bit more when we get back after we've been rejuvenated and gotten some rest, right? So these are just kind of some general, inspiration things. Taking care of your health. We've all talked about some of these things. If you guys want this slide or want this slide deck, I'll come up and give me your card, or I'll give you my card, you can email me and I'll send it to you. These are some coping strategies. My favorite breathing technique, PS, that I stole from a family is smell the roses, blow out the candle. So smell the roses, you breathe in, and then you blow out the candle. And you do that 2 or 3 times. If you were in my previous session, I made you guys do it 3 times. It really works. These are some ways that you can ask for what you want. If someone says they want to help, you're like, hey, can you get us a DoorDash card? Because sometimes I can't cook or I don't want to cook. And no, thank you, I don't want your casserole. No. Or set up a family calendar so you guys can, communicate with other people about what's going on. And if you need transportation, asking for that, cleaning services, things like that nature. These are some of the HD or some of the youth resources that are available. Those are the QR codes that hopefully take you to those places. they should. There's lots of online education for JOHD. There's JOHD focused research, so there's Join HD and Kids HD and Change HD. Both of them are observational, so they're not treatment trials. And thank you for coming. Please call your centers of excellence.
Say one thing that we've been asked to say.
Oh yeah.
Just to remind you that there are some pop-up studies going on here at the meeting.
Oh wait, we need your mic.
Oh.
They need your mic.
There are some pop-up studies that are going on here at the meeting. One of them is sponsored by CHDI, and they said that it involves minimal risk procedures. It's very easy. It's going to give them pilot data for a larger study. They're going to be talking about data collection, and they want to do it here at the convention. There's only the rest of today to do it, and to do it, you go to.
I don't know.
Keep going.
Isn't it on?
Keep going. Doesn't matter what
Oh.
it is. I think it's on the last slide. It tells you where. Oh, okay. Where is it? Research? Okay.
Yeah,
Who
I
can
think it's.
participate? Keep going. Where? Wait.
Oh.
The last slide, the only one that was important there is where. Oh,
Who can?
no.
Is this
So
it?
it's at
Oh
the
yeah.
rooms 304, 305, 306, 307, 308, and 309 today until 5 p.m. So go there and help them. What? Yeah.
So sorry, we talked too
Oh,
much,
question. Go ahead.
Go ahead. You can tell
we
we're
had
passionate.
to rush. Sorry. Yeah.
Thank you.
Thank you.